Welcome. I appreciate everybody coming here this afternoon. Let's see. I'll put this on. You guys hear me in the back there? Okay? Good. All right. Well, what we're going to talk to you about is what colon cancer actually is, where it comes from, and why it's so important to discuss when you're healthy, because this is something that we can do a tremendous amount for by preventing, and even patients who have it, as you'll hear, how we treat it. So there's tremendous hope in this disease. Let me start with what I consider the largest paradox that exists with this disease. Colon cancer remains the #2 cause of cancer-related death for men and women combined. And yet, it's the most preventable and curable of cancers that we know. The only one that is equally as preventable is cervical cancer, which, as you know, is really dropping and almost disappearing, thankfully, for all the research that's been done with pap smears and now with the etiology, which we think is a virus. Colon cancer, we haven't come as far with knowing what causes it, although I'm going to show you that we've learned a lot. But we can prevent it quite as easily. And we are seeing the rates of colon cancer and colon cancer-related death drop, which is really all the good news. So this is the basic concept that we try and throw out in the public, meaning something simple that people can grab onto. How can I prevent colon cancer? Well, we believe that all cancer of the colon comes from a growth called a polyp. Now, they may not all look like a lollipop or a mushroom like that, but they could be very flat. However, they are a growth in the colon that if we see it, particularly with a colonoscope during a colonoscopy, we can remove that polyp and prevent it from ever turning cancerous. So we believe all cancers come from polyps, but not all polyps turn cancerous. And if it starts to grow and spread into cancer, which is represented by this pink blob, the yellow representing the wall of the colon, if we, let's see, I don't have a pointer, but oh wait, maybe I do. Yes. So if this is our cancer, and this is the wall of the colon, an early cancer can just be removed and is quite curable. As the cancer grows through the wall, it can start spreading to lymph nodes or to other organs like the liver. Then it becomes a little bit more difficult to treat, although still sometimes it can be curable. So the sooner you get to it, the higher rate of cure we have. So early stage in this patient, they may not even feel anything because this is just a little bump on the inside of their colon, which is the large intestine. Whereas as it gets a little bigger, it could cause more symptoms like bleeding or change in bowel habits or even blockage called an obstruction. Now this is an actual polyp. You think you guys can handle the pictures, or is this, it's not too graphic for you? This is a polyp, and I want to just show you. Okay. I specifically hooked up my computer so I wouldn't get into trouble like this. Okay. So here's, I thought the video, you know, what we look at tends to be living images. Here's a polyp, and what you're looking at is the inside of the colon during a colonoscopy. Now, what people don't realize is actually a polyp is a growth that's very easy to see in certain cases, and we could use this blue light to see the difference of the texture of the polyp. And it has sort of a villiform, as it's called, pattern. It looks very different because it's an abnormal growth, but a polyp is still benign. This is not cancer. And what we can do is go in with our scope and a device called a snare and actually remove the polyp by putting the loop of wire, which really looks like a lasso, around it. And once we get it surrounded by the lasso, we will close. This is the catheter called a snare, and you'll see a loop of wire come out. Right now, what we're doing with the snare is we're actually looking at how the polyp is attached to the wall. You see the polyp has a little stalk. It literally looks like a little mushroom. And look how clean it is, by the way. This is the importance of a good prep. People will say, how can you do this? It's so disgusting. How can you look inside someone's colon? Actually, it's very clean and has almost a natural geometric beauty to it. You know, the inside of the body is actually really quite an interesting device. Now here's the loop of wire coming out called the snare, and it loops around the bottom of the polyp, and we push the snare forward and close the loop of wire, and then what we do is we have a foot pedal, which we could push on the foot pedal, and we'll actually burn the polyp off. No blood here, you'll see. What's happening now is there's electric current going through, and the polyp is going to be burnt off, and you see it fell to the opposite wall, and here's the bottom. And this will heal. You'll never even know. We're just rinsing it off now with a water jet, and you'll never even know that polyp existed. So now we've prevented that polyp from ever having the opportunity to turn cancerous. I hope that wasn't too graphic for anybody. Now this is what we're trying to avoid. This is what cancer looks like. You can see it's no longer polypoid. It's beginning to have a indentation in the middle. What's happening now, as the tissue turns cancerous, it starts growing into the wall. And instead of growing up, it's growing in. This is what we want to avoid. But here's the problem. You know, we live in a society that has great food, but not necessarily the healthiest food. Anybody from Philadelphia? Anybody know what this thing is? It's called a Philadelphia cheesesteak, okay? This happens to be my favorite place, Pat's. You have the meat simmering on the griddle here. You have cheese substance. It's not really cheese. It's a pseudo cheese called Cheese Whiz. And this is the problem. The American diet is this kind of concept. You know, close enough. This is the American version of the balanced diet. Close enough. But the truth is, just so everybody knows, there are things that actually improve our cancer risk, particularly things like vitamin D, meaning decreases the risk of cancer when I say improve. Aspirin, believe it or not, actually has some protective effects against colon cancer. And things that we know increase the risk of colon cancer in excess: tobacco, alcohol, and red meat. Doesn't mean you can't have any of these. Well, I would say you shouldn't have tobacco, period, because of all the deleterious effects. But in moderation, alcohol or red meat's okay, but in excess can increase the risk. So what of our recommendations? So there was a multi-society task force that got together of all the societies that made the recommendation of 2 divisions of risk. Tests that detect the polyps and the cancer. So these would be tests that can actually prevent cancer, right? By finding the polyp, you remove it, you could prevent it from turning cancerous. And tests that detect the cancer at an early stage when the cancer is more curable. So here are the tests that detect polyps or cancer. We have a flexible sigmoidoscopy, which can be done every 5 years, a colonoscopy, which could be done once every 10 years, a double contrast barium enema, which, as I'll show you, has disappeared because it's just not a good test anymore, but it's still one of the recommended tests because this is an older recommendation, once every 5 years. And the new kid on the block, which I'll show you some data, this is really cool. It's called CT colonography. Anybody know what the term is in the newspapers that they call this? Virtual colonoscopy, exactly. Now you'll see, although it is kind of cool, has a cool name, virtual, it's not that different from standard colonoscopy in many ways. Flexible sigmoidoscopy is just like a colonoscopy, except it only looks at the very bottom of the colon. And that's fallen out of favor also a little bit in this country, because if you're already looking at somebody's colon, you already have a scope in your hand, most people feel you may as well look at the whole colon. It's been likened to doing a mammography on one breast. However, it is an easier exam. You don't have to have sedation for this flexible sigmoidoscopy, so there's still potentially a role for it, and it's one of the recommended lists. Now, the tests that detect cancer generally are stool-based tests right now. These 2, high-sensitivity guaiac and fecal immunochemical tests, are actually tests that look for microscopic blood, small amounts of blood that you can't see in your eye, but these tests can pick up in the stool. The stool DNA is something that's being developed, but it's very exciting to us. There's some good preliminary data, and so although it's not quite there yet commercially, I think you might be seeing this test on the stool, which could look for abnormal DNA that might detect cancer. And there's something called the U.S. Preventative Services Task Force, which is the government-mandated group that gets together and looks to see whether or not different tests are justified, and colon cancer screening got the highest grade, a grade A. So it works, and actually the government in their own review agrees. What are their guidelines? Very similar to what we just saw, except they do not include stool DNA and CT colonography, a virtual colonoscopy. And because the government group doesn't recommend virtual colonoscopy, sometimes it's very difficult to get that covered if that's the test someone chooses to do. Now this is the data on the barium enema. I just thought I'd throw this out to show you that barium enema misses 15% of cancers and over half large polyps. So not only is it a bad test, but it's uncomfortable, it's gone. barium enema, you will not see people doing barium enemas much anymore. So even though it's on the list, I just wanted to let you know. So what about patients who are at higher risk? Well, we start at age 40 if anybody has a family history of colon cancer or related cancers, particularly uterine cancer, ovarian cancer, and if there's clustering of breast cancer in the family, someone needs to talk to the doctor whether or not that may represent a familial cancer problem where colon cancer might need to be looked for at an earlier age. Now, if someone had cancer at a very young age, say at age 42, they would start screening at age 30 or 32, 10 years before the youngest person in their family had cancer. And what's interesting in this graph, here's the little graphic of the cancer, only about 15 to 20% have that family history of cancer. Most patients who are at average risk are the ones that are coming down with colon cancer, meaning most people who develop colorectal cancer, 75% or so, have no family history of colon cancer. So one of the myths out there, it's not in my family, I don't have to worry about, doesn't hold true for the majority of patients, just a smaller group. You need to know your family history. That's crucially important because you might need to start screening earlier. But if you have no family history and you feel well, that's no excuse not to get screened. So here are the new tests, CT colonography or virtual, and some of these stool tests. So this is the stool test known as the FIT, some people call it FIT. It's the fecal immunochemical test. And it uses a paintbrush to really just look for microscopic blood. It's very simple. You do your business, you take the paintbrush, you just a little wiggle the paintbrush. You don't have to touch anything, you don't have to manipulate anything. You then take the paintbrush and you put it on the card. It goes in an envelope that you're given off to the doctor's office or to the lab. Very simple, very accurate test, much better than the conventional test that you would do where you had to touch the stool with the stick. Pretty gross, actually. This is really easier and a better test. So I would say that if anyone's going to do a stool-based test, this is the one to ask your doctor about, FIT. This is what the virtual colonoscopy looks like. Remember you saw the regular colonoscopy? This is a three-dimensional reconfiguration of a CAT scan, and it's really cool. I mean, it's amazing. But there's some things that people don't understand. It definitely has the coolest name, but it's still very similar to a colonoscopy. You still have to take the same bowel prep. How many people are you surprised to hear you have to take the same bowel prep as colonoscopy for virtual? Yeah, I was surprised to hear that too, because if you're already taking the prep, and this is what sort of gets the logic in why you would do this, you may as well have the regular procedure, which can not only find the polyp, but remove it. And that's why this test hasn't caught on as quickly. And a small tube is used in the colon. You actually have to inflate the colon, so a little tube is put in there. And if polyps are detected, you need a regular colonoscopy. And that's why a lot of people, if you're already going through it, you may as well just have the procedure that can remove the polyps. However, it is a really cool test. And if we could do it the same day, and that's one of the things we're trying to do at NYU, get the virtual colonoscopy done, and if you find a polyp the same day, get your colonoscopy. Then you don't have to re-prep. You can get everything done in one day. And hopefully we'll have that set in the next few months here. Here's what it looks like in colonoscopy, a little polyp. And on virtual, it looks like the same thing, only it's a configuration of a CAT scan rather than an actual picture. And this is kind of cool. This is an actual movie of a virtual colonoscopy, what the polyps look like. And we're not scoping the patient. This is a configuration, a 3D rendering done here. This is actually the tube. That was the tube that blows the air in. But here's a polyp on the virtual. It looks very similar. So it's a very powerful test, except it hasn't caught on that much because people still don't want to get two tests if they have a polyp. So I think it's very good. A number of patients, up to 17%, will require subsequent colonoscopy, so people have to recognize that. And if we have smaller polyps, can we just leave them in there, or do we have to remove every polyp? We don't know yet, so we have to understand this a little more. Just going to end with a few teasers, okay? Now, I have to make a comment here, okay? I got to come out, just let you know. These things are not available yet, so I don't want anybody leaving here. I want everybody to be very clear about it. Don't leave here saying, oh, I'll wait for that pill, because this could be years away and we haven't validated. But I want to show you some of the research we're doing to make things better. This is a capsule that you swallow. And if these are what polyps look like normally, the pill can actually take pictures of them floating in clear fluid. And it's a camera. It's as it travels down, it's like that movie Fantastic Voyage. As it's tumbling through, it's taking pictures. It might be able to pick up polyps. We're still a few years away from this, but this may be something down the road. This is a scope that actually elongates from the tip by use of a motor, and it's literally a robotic or remote control scope, which we're actually using here now in a certain subset of patients who may not need sedation. This scope may be so comfortable going through that it may not need sedation. And this is actually having it happen. The doctor's playing a video game here practically. And you'll see how comfortable, look at this patient. He's having the procedure done. It's like he's watching the baseball game or something on TV. Very comfortable. The doctor's doing the procedure. Again, something down the road that we'd like to see, but not quite ready for prime time in all patients. We're putting a balloon on the colonoscope to make it see better. We inflate a balloon. As we pull back, we could straighten the folds so we could see the polyps better. And we're also expanding our scope, which a normal view gives us just the front view, but by putting lenses on the side, we can get actually side views. So all of this is very exciting. We have all kind of new technology, and what I want to leave you with is just that it works. This is the incidence of colonoscopy going up, and we're seeing the incidence of colon cancer drop and the death rate of colon cancer drop, which is an incredible drop of cancer incidence, this is one of the largest drops of cancer incidence we've seen in any cancer. And what does it mean? In the 4 years between 2003 and 2007, 33,000 deaths were prevented through intervention and prevention of colorectal cancer screening. And when you try and figure out what is that number, it's Yankee Stadium. I mean, this is 50,000 people. It's a tremendous number of people. So we're doing a great job with trying to get the word out. But the most important thing is that people understand the importance of not only prevention, but early detection. And you'll hear that even in the advanced cases of cancer, there's tremendous hope because we have new incredible treatments coming down the pike as well. So thank you very much for your time.